Hi, sir.
नमस्कार अरुण जी.
Thank you, sir.
नमस्कार अनिल जी.
Thank you, sir. Welcome.
नमस्कार गुप्ता जी.
Dr. Gyani.
नमस्कार सर. नमस्कार.
Namaskar. Welcome.
Thank you sir.
नमस्ते.
Namaskar, sir. Namaskar.
नमस्कार डॉक्टर गुप्ता.
नमस्कार सर, कैसे हैं सर?
बस बढ़िया सर.
डॉक्टर गुप्ता ने तो बिल्कुल ड्राइव इन कर दिया. Excellent.
अनिल जी, आजकल तो तुम्हारे पड़ोसी हैं गुप्ता जी.
कहाँ पे है सर?
मैंने कहा नोएडा में, ग्रेटर नोएडा में तो आपके पड़ोसी हैं.
हाँ सर.
सर कहाँ पे हैं आप?
मैं तो जेपी विस्टाउन में हूँ.
मैं आपके सामने ही हूँ बिल्कुल. और क्या, क्रॉस द रोड.
क्रॉस द रोड. ये रोड के इस तरफ है, आप इस तरफ है.
बिल्कुल सर.
और एसएल गुप्ता साहब भी हैं सर.
अच्छा सर.
मैं तो डीएलएफ में हूँ सर, फेज 3 में.
अच्छा अच्छा.
यस सर.
हाँ जी, good afternoon, Anil. This is Dr. Arvind Lal here. SCL, nice to see you. Dr.
Yes,
Gyani
sir.
sir, क्या हालचाल?
अरविंद जी.
वेलकम सर. वेलकम सर.
Nice to see old faces.
डॉक्टर गिरधर जी.
नमस्कार नमस्कार.
कैसे डॉक्टर ज्ञानी?
ओ बस बड़ा थोड़ा बहुत सुधार हो रहा है.
आपके होते सुधार नहीं होगा तो किसके होते होगा?
बिल्कुल सही कहा.
ज्ञानी साहब क्या शुरू कर दें? कैन वी स्टार्ट?
यहाँ डॉक्टर गुप्ता भी आ गए, डॉक्टर अरविंद हमारे, और अभी डॉक्टर गौर नहीं आए अब तक.
डॉक्टर गौर बाद में ज्वाइन कर लेंगे.
अच्छा
तो
ठीक
ये
है.
आने वाले ही होंगे.
हाँ ठीक है ठीक है.
वी कैन स्टार्ट. और रिक्वेस्ट ये है कि डॉक्टर गौर को बाद में ही रखें.
हाँ जी.
और
हेलो. नहीं, कुछ नहीं किया.
so Dr. Gyani, can we start now?
Yes please, we can start. Yeah.
Yeah. So welcome to this webinar to ensure patient-friendly quality healthcare in this COVID-19 times and beyond. And Dr. Girdhar Gyani will chair the session, and eminent speakers are there. And this webinar is mainly focused on patient-friendly. This means at the center of all things, patient is there. So I will request learned speakers to share their views, how to deal with second wave and third wave, if any. Hopefully it will not come, but how to deal with this. This is a question mark. And that's why we are in this webinar and your expert views on this. Now I will request Dr. Gyani to focus light on this.
Okay,
Dr. Gyani,
namaskar.
please.
Yeah, namaskar. Namaskar, Dr. Anil Garg. Thank you very much. And I have got a team of very experienced and very senior colleagues with me. While I am representing the Association of the Hospitals, but you know, my other three colleagues, they are running the show right on the ground. So that's what I am expecting from them, that what I will present a little bit of overview of what is the scenario today during the COVID and what we are expecting in time to come. My colleagues will be able to give us the ground reality, what is happening on the ground and how they are dealing with the COVID-2 and possibly what is their preparation plan for COVID-3 if at all it comes. So let me just share my screen. I'll show some 4 or 5 slides just to, you know, put the perspective in place. So the topic is this: ensuring patient-friendly and quality healthcare. Now, I generally, you know, always believe that before we discuss the COVID, there is something which we have to see, whether COVID or no COVID, where do we stand in terms of the healthcare statistics. So this slide shows you in very simple perspective that when a year and a half back, there was a WHO sponsored rating of 195 countries on the effectiveness of the healthcare, India was rated at 145. I have gone through this report in detail. The main reason, if you ask me, was the poor accessibility, where we got very low score. What was shown in that study that India may have, of course, the number of beds also were very short, 1.3 per 1,000. That means we need still 2.5 times more number of beds overall. They have shown around 19 lakhs beds in our country, roughly 50-50 in private and government. So we are still way behind. But where we got poor score was, for example, an example was given in Telangana state, there were 125 hospitals with 100 bed size and above. That means we call them tertiary care 100 bed and above. Out of 125, 118 hospitals were listed only in city of Hyderabad and Secunderabad. So that shows how poorly remaining district of Telangana are served for the tertiary care, let us say. Now this story is repeated across Delhi, Bangalore, Hyderabad, or Chennai. You go to all metro towns, you get, you know, for example, Delhi is the privileged city. It has got the highest bed strength or bed density per population. But still, we are nowhere because adjacent states, UP, Bihar, Madhya Pradesh, Chhattisgarh, right up to Jamshedpur, the people come to Delhi. Whenever there is some little bit of serious issue, they just rush to Delhi. So that's why Delhi gets overwhelmed all the time. So this is where I'm flagging this concern, that unfortunately we have not been able to distribute our healthcare establishment across the regions of the country. There are, of course, reasons for that. I think my colleagues will be able to give us that perspective. Doctors, of course, we are short, but more importantly, we are short for the specialists. Not so much about the MBBS, but about the specialists. And governments also keep telling us that 78% vacancies are there of the specialists in their government hospital, community health centers and district hospitals. So I think we are way behind there also. Nurses is the same thing. Surprisingly, that country like India, till about few months back, we didn't have any council to regulate the allied healthcare workforce, which is very important workforce, let us say it here. Similarly, of course, no compliance very poor compliance on regulation and quality. So this is where we are. So I thought this is very simple because we always are focusing on COVID. Forget about COVID. Even without COVID, we are nowhere near. We do not have the basic infrastructure. So these are the challenges, I thought, which my colleagues will be able to give us a little more detail, that all the time for past 6 years, if you pick up any conference, seminar, the first speaker will say, India is on the crossroad in terms of healthcare. Today also we are on the crossroad. We are not able to cross that crossroad. So we are really not sure. And during the COVID-2, that is first wave, we heard a lot of discussion. It went to the Supreme Court, and almost everybody among us was made to believe that healthcare is going to be nationalized. Because during that time, there was a lot of hue and cry, 80% beds to be reserved here, 70% there. And then there are overcharging, so and so. So many stories came and they were put up to the Supreme Court. And of course, luckily, I think the Supreme Court is wise enough to understand whether nationalization is the answer. In fact, I am the one who made a small paper. It didn't get much circulation, where I said, instead of nationalization, why not we privatize entire healthcare system and bring a strong regulatory body like IRDA, like TRI or anyone. I mean, very professional regulator comes and we privatize entire healthcare. Anyway, this is my personal view and I still stand by that. Healthcare regulatory pressures keep on changing depending on what government comes, depending on what situation comes. Everybody wants to regulate the healthcare and regulate, not healthcare, regulate the costing. And that is a discussion today, quality and costing and the patient friendly. All these three are connected with each other. Without knowing what is the cost of healthcare, I have been in the government. Dr. Arvind Lal has been working together. We have been working on many committees. I think he knows, I know. Till today, none of us knows. None of us have done the study which government accepts on the costing. Serious efforts were done by FICCI, where Dr. Arvind Lal took the lead role to do the costing of all procedures. But government says, no, this was done by FICCI or this was done by so-and-so, although government agencies were involved, AIMS. But anyway, point is, on paper, there is no costing done till today. And government continues to fix the prices of the medical procedure on purely ad hoc basis. I'm very sorry to say that. So this is the kind of healthcare reforms. Each state government I have been studying, there will be a health minister and there will be health education minister. That means the education in this country has been treated separated from the healthcare. The minister which is looking after the education is not bothered about what for he is producing doctors, what for he is producing nurses or allied healthcare. He is running his own shop. I'm calling it shop. So this is a total disconnect between, unless you see, you will not be able to bring reforms in the healthcare unless you bring reforms in the education system. And there are lacunas in our councils, medical, nursing, allied, everywhere, So this is where we have not been able to bring reforms. Of course, the fundamental remains, which I don't think any government will be able to solve, the minuscule public funding. 1.3% of GDP, they are planning to go to 2.5. I don't know when they will go to 2.5. Even 2.5 is nothing. Thanks to private sector, they have invested till today 3.7% of GDP. And if they are encouraged, which I am again sorry to say that there is no encouragement, no incentivization to the private sector to establish hospital, this can go up to 5%. Private sector share alone can go up to 5%. And this is all reasons we have shortage, then attrition of the human resources. We keep complaining of the attrition, particularly about the nurses. I am here to tell you why not. Why not nurses should leave our country? We do not pay them the salary which driver gets. The money which I give to my personal driver, we do not pay to a BSc nurse. And we are expecting that these nurses should continue in our country. And I think there is no career progression for nurses. I think this is the way we have really been treating the education sector of our country. Soft skill and of course, patient interface deficit, that I think I will leave up to my colleagues. They will be talking to you. Where are we lacking? And because the tier 3 towns, I am reminded of the Honorable Prime Minister saying in 2018 in Gyan Bhavan that I want 3,000 hospitals to be set up by the private sector with 100 bed and above. To best of my knowledge, even one hospital has not come up after this announcement. We know the reason why nobody will like to set up a hospital in tier 3. It will be totally unviable. Specialists are not available. Electricity is coming at the commercial cost. Clearances takes 1 year time. If I want to set up a 100-bed hospital, I will take minimum 1 year to get clearances from 37 departments, And of course, the good point is that growing consumerism is coming. Now, that is where my colleagues will tell us, how actually they will be dealing with this consumerism, the demand on healthcare, the way it is coming up. So this is what my simple point is, that during COVID, the management was, I'll give just 2 slides. One is this one, my own perspective, that how we have managed. In fact, we managed first COVID wave 1 much better, though it was new to us. While COVID current wave, of course, because of the nature of the variants, I know there are problems, but somehow I think even on the management side, I am very frank to say we had serious crisis of leadership at political level, bureaucratic level, and even at the medical level. There has been the problem. I don't want to analyze here in this short period of time, but what I wanted was, at this point of time, it was required that we lead from the front. I have served in Dr. Arvind Lal. I have been in the civilian for the defense R&D for 15 years. And we were taught that even when the commander is losing the battle, he doesn't leave the ground. He remains in the front and along with the soldier try to see what best can be done. That I didn't find happening in this period of time. Of course, other things here kept on happening. The occupational health and worker safety was the prime concern, because we were all worried that how do we take care of our doctors, nurses. It's very sad to see so many of our doctors have succumbed to COVID. So many nurses died. And this is, of course, very sad story. And because of that fear, I think we had, bit of limitation on how do we really manage the facility during this tough time. And this last slide is that during this, the topic here is quality versus cost. You see, during the COVID time, financial implication during wave 1 were much higher, because we were told not to admit COVID patient. We had about 30 to 40% always beds vacant during that time, but we were not able to take the patient. And our EBITDA went to negative. We had to cut the salary of doctors and our staff by 30 to 50%. This is a fact, everybody knows about it. Cost of PPEs, and this time cost of oxygen. Let me tell my friend Dr. Anil Garg here that the oxygen consumption in general ward went by 3 times. And cost assumption, Dr. Gupta will subscribe to that. In the ICU, it went up to 5 times. And cost of oxygen itself became 2 to 3 times. So you can understand the cost implication which hospital had to pay during this current wave. On top of it, state governments did capping of the treatment cost. And you'll be surprised actually. One government is capping at 10,000 rupees per day, another government 7,500, and third government is doing 4,500. I am unable to understand what is this calculation they are doing. Same country and 3 states. Why 3 states? All states have got differential costing and they have fixed this costing. Now you see, as a hospital, having served in government for 35 years and now in dealing with the private sector, you see, if I have got 40% cash paying patient, I can still cross subsidize the money received from there for the COVID. But in this current way, all beds were COVID. Government has blocked 100% beds in many hospitals and 80% beds in many hospitals. Many means all. So that means as a hospital, we are not left with any cash paying patients so that I can, charge my rack rate from them. So we were providing treatment at that fixed cost, 4,500, 7,500 or 10,000, depending on which state we are. So as to say, even insurance companies started exploiting hospitals. There is agreement between hospital and the patient and the insurance company, and they have to pay for the treatment as per that agreement. But once they saw, oh, that government is paying you only 4,500, so why not we also pay you 4,500? So I think this is the way hospitals have been exploited during this period of time. So all this, when you try to squeeze the cost, who will be suffering? I can tell you, I don't want to go into detail. The quality and patient safety will take the back seat. It will be severely compromised. We will not come to know that how patient safety will be compromised, and it will have impact on morbidity and increased mortality. I think governments must understand this simple fact that if you try to squeeze the hospital, that means you are telling them, do not follow any protocol. There is no money available to you. Okay, I mean, all sorts of things. This is a topic by itself, and this is my strong area also, having worked in quality for now almost 3 decades. So the learning now is, the slide is, I found during this COVID, so much ambiguity coming from of the disease management protocol. I want Dr. Arvind Lal to spell a little more on this point. WHO, Ministry of Health, ICMR, CDC. I didn't find, the responses was coming from them, haywire, not synchronized, and hospitals were really under severe constraint to know what really are the protocols going on. This was the situation in Delhi. You can imagine what will be the situation in tier 3 cities. So this is my major concern. Second point is, we have missed the golden opportunity of collecting the data during this pandemic. Even the mucormycosis is the one issue which we know is only India specific. I am not finding these cases anywhere else in the world. We could have, I hope some people are generating that lack of hospital preparedness in collection of data. This is again, we are missing. All state government, liberally, they were doing, favor to hospital. Okay, increase the bed by 30%. My God. And then so many gurdwaras, so many NGOs, they say 500 beds we are putting here, 600 beds we are putting here. Nobody asked this question when hospitals themselves do not have the doctors and nurses. How come these 500, 600, 700, all around beds will be maintained? I think nobody asked this question. And you can understand, when we set up 500 bed outside the hospital, the oxygen was taken away, which was for the hospital to those NGOs, which cannot do the medical treatment. Let me be very frank, but oxygen was taken away. And that is where we ran the huge shortage of oxygen. So I think this is where I'm saying the major breakdown came in the communication between the government and private sector, between the government and regulatory body, between government and ICMR, and finally between the hospital and poor patient. So you are talking of the quality healthcare. I found, because of this huge constraint, shortage, miscommunication, We could have done much better, but we somehow, I think, lost this opportunity. The basic fundamental remains that first line, that we do not have the minimum basic healthcare infrastructure. Unless you have got that, you are not able to manage the normal disease control. And we are talking of the COVID and that too of this mutation which have come this time, very difficult. But at the end of the day, I will say, in spite of all that, I'm not criticizing government here at all, but private sector stood the ground. Because why I'm saying so? Because private sector has got the critical care beds. Why I'm not able to, say something about the government? Because government by design have hardly 10% bed as ICU. They kept on increasing, but the private sector normally had 30, 35, 40% kind of ICU. So it was the private sector, you can say, which took the brunt or majority of the COVID care. And still, in spite of higher mortality this time, still I think we have been able to minimize the mortality. So you must give credit to our doctors, nursing staff, and healthcare professional for managing the COVID current wave. I think anyway, this is of course post-COVID. I don't think this is a topic. I thought I will just show it that what is going to be the post-COVID. Post-COVID, I will still like to say government that they must incentivize 100-bed hospital for tier 3 cities. They must produce higher number of specialists. Without that, nothing can happen. And the NGOs must now come forward to work on promotive and preventive healthcare, covering drinking water, sanitation, hygiene, and nutrition. I know 30,000 crores have been earmarked, but I don't see anything happening on the ground. And finally, the topic of the day is how do we become the quality healthcare providers? So from patient-centric, the hospital post-COVID will have to become patient-driven. That will be our new avatar. I think so. My point was, let me just give the background overall, this kind of, so that my colleagues and Dr. Arvind, of course, is very experienced person. So I think I will invite maybe Dr. Arvind first to tell us, where we are, and then Dr. Gupta and Dr. God after that. So Dr. Arvind, please come in.
Thank you, sir. Thank you very much.
Sorry for interruption. Dr. Gyani, I have to say two things in between. Two things. Brigadier Padma Shri Dr. Arvind Lal, I will take 10 minutes from you before you start. Just 10 minutes, please. So first, I will like to speak a point that our focus is on patient and patient. So this is a question mark, and particularly poorest of the poor. This means villages. We are not talking of Delhi or NCR and others. We are concerned, your concern, I want to have attention that poorest of the poor. And as far as COVID is concerned, Mr. Anil Rajdan and Mr. V.K. Garg is here, Dr. V.K. Garg is here. They say that in April 15-16, when we organize World Conference on Healthcare, we should honor heroes of COVID, those who are living, doctors, nurses, paramedical staff, those who have served this nation in difficult situations. And with your permission, Dr. Lal, Mr. S.L. Gupta, Dr. S.L. Gupta, the medical director from Batra Hospital, has to leave. So with your permission, if he is given 10 minutes time, please. Dr. Lal, please.
Okay. So, SL, would you like
If it
to-
is,
Yeah, it's okay with me. No problem.
Yeah.
I will request. Okay, greatness. So, Dr. Gupta, please confine yourself for 10 minutes. This is too harsh a word, but I will request that your wisdom should also be there in this pandemic times and future. Dr. S.L. Gupta, please. Dr. S.C.L. Gupta, please unmute yourself and speak. Is that okay with Dr. Gyani?
Yes, of course. Welcome, Dr. Gupta, Dr. S.C.L. Gupta.
Yeah.
Yes.
Please unmute. Yeah, it's okay.
I'm sorry, since I have to go somewhere for a meeting, urgent meeting, I'm taking this liberty and requesting you to please grant me this time. Thank you very much, Dr. Girdhar. As long as calculation is concerned, I have got a calculation where the minimum expenditure in an isolation ward is about 38,147 rupees per day. You are talking very rightly that 10,000 rupees in Delhi for isolation bed, 15,000 rupees per day for ICU, and 18,000 rupees per day ICU with ventilation charges. Now it's ridiculous. No private sector can survive with this rate, but really thanks to everybody that they have managed beautifully with the order of the government and the government rates. I have got a full calculation of each and everything. In 1 minute, I will say ICU ward charges, central government charges are 2,000 rupees per day. So keeping these CGHS charges when the rate is coming about 38,147 rupees per day. Think about if somebody is charging normally. Investigations charges per day is 9,990. And if I give you the detail of investigations charges, CBC at least once per day, 135 rupees per day, that comes about to 1,350. LFT charges, if you are doing only twice in a 10 days stay, this comes to 259 rupees is a CGHS rate, that comes to 518 rupees. So this way, if we calculate, I will provide you the good calculation. Moreover, I'm coming to my point. A keynote address on how to ensure patient-friendly quality healthcare in the COVID-19, especially in second wave and third wave times. Sir, the COVID pandemic has taken a very heavy toll in its first and the second waves. The strain that was placed on the healthcare resources was especially immense in the second wave. We are all aware that the caseload was especially disproportionately higher in Delhi. I don't know why. The healthcare system in the capital of India nearly collapsed under the continuous assault of COVID. The heavy caseload also took a toll on the quality of the services, as the staff and the doctors could not cope up with the heavy caseload. In order to improve patient friendliness and the quality of the healthcare during COVID pandemic waves, it is essential to keep the following points in mind. The patient and the neighborhood of the hospitals have to be introduced to the essentials of keeping themselves safe. As much more concentrated effort is required from the government to educate the public about the essentials of masking, social distancing, and hand wash techniques. This will go a long way to ensure that the pandemic doesn't explode beyond the point of easy manageability. The quality of the service is inversely proportional to the case load. Reducing the size of waves can prove to be highly beneficial. Hospitals will have to employ a combination of online and offline approaches to maintain the patient-friendly nature of services with an eye on reducing exposure of patients and healthcare workers. All efforts have to be made to ensuring minimum wait time in the patient system for the patients with adequate social distancing, safely protocols when they visit the hospital physically. Screening of the patients and the hospital staff at entry point is also essential to ensure the safety of individuals. Prompt attention and treatment to all patients will also go a long way in improving the quality of the patient services. This also entails regular and ongoing training of the doctors and staff of the hospital. Maintaining the chain of communication and keeping the patient and his family informed on a regular basis is also essential to maintaining the confidence levels of everybody. The patient and his family will have to be increasingly viewed as a partners, not just as recipients in the provision of a treatment. Robust SOPs for treatment and safety have to be designed so that patient friendliness and quality are maintained in the hospital setups. The healthcare community will have to learn from each other's experiences and share this pool of new knowledge through such webinars and teaching and learning sessions as we are having right now. Supplementing treatment of COVID patients with psychiatric support and mental support care is also extremely important given the psychological trauma it causes to patients and their families. It is paramount to treat COVID patients with a great deal of empathy and care. COVID is a dehumanizing disease. Patients have to be given confidence in their recovery and are to be educated about the warning signs. The doctors and nurses have to be sensitive to the rehabilitation needs of the patient and should ensure an early start to the supportive services that can enable the patient to deal with the challenges independently. Above all, it is extremely important to deal with the new challenges that have become obvious in the second wave of pandemic. Delhi, India, and its hospitals have to become self-sufficient in oxygen requirements. There has to be a dedicated effort for maintaining adequate stocks of the essentials and adjunct medicines for the COVID treatment. In conclusion, ensuring patient-friendly, quality healthcare in these times of COVID-19 depends on redesigning our thinking and modulating our behavior. We have to accept that this infection will keep presenting newer challenges and that we have to keep evolving in our responses in order to stay a step ahead, not 2 steps behind. I think I was within my time limits. Dr. Gyani, I will provide you in detail the expenditure, how I have calculated 38,117 rupees each and every naya paisa as per the CGHS rate if we are going through this. Otherwise, expenditure will be coming about 70,000, 80,000 rupees a day if you are really managing the COVID patients, the comorbidities, the dialysis charges, so many CT scans, so many MRI scans, and so many investigations and costlier antibiotics and other drugs. Thank you very much.
I will get in touch with you through Dr. Anil Garg, and I will be very happy to interact with you and share with our calculation, your calculation, and I think you will be part of our own initiative in time to come. Thank you very much, Dr.
Thank you, sir. Thank you. I'm
Now,
sorry
I
to
think-
go.
No, absolutely fine. You actually gave us very insight about it. When somebody says, I have done the ground calculation with naya paisa, I think it gives us that confidence.
Thank you, sir.
Yeah. Now I think Dr. Arvind Lal will be able to take it forward from here. He's another veteran. I don't have word of praise for him. He's
Thank you,
really a
thanks.
very useful person for us. Let me now call upon Dr. Arvind Lal.
Thank you, sir.
Thank you, Dr. Gyani. And first of all, I would like to thank Dr. Anil Garg and all the other luminaries like Dr. Uttam Sharma, Dr. SCL Gupta, my old friend, Dr. Vinod Garg, Dr. DK Gupta, Dr. Ravi Gaur, if he's joined. So thank you for giving me this opportunity of sharing my thoughts. First of all, I must confess that the topic is so wide and varied and complicated that, just one kind of a interaction is not going to sort out all the problems. And in case, in a lighter way, I'm saying if our saying would have solved the problems everywhere, India would have been on a different note. So anyway, let me start in whatever, I have. So, ladies and gentlemen, the world over, there has been a great war with the COVID-19 pandemic. And this has lasted for nearly 1.5 years now. This pandemic has claimed over 35 lakh lives all over the world and also inflicted a severe economic recession, which is unheard of so far in the world. As a developing nation, the impact on India is huge. And India mounted a very strong response with multi-pronged efforts to contain the infection in the first wave that included a strict lockdown, extensive test, track, isolate, and treat strategy, and strong messaging on basic preventive measures like the use of face mask, frequent hand washing, what you call, compliant COVID behavior. But now we have the second largest number of cases in the world in the second surge and the third largest number of deaths in the world. So India was able to manage the first wave fairly well. Maybe that is what gave us the false sense of satisfaction. But after that, a false sense of normalcy crept in, and we did not take adequate measures to stop or prepare for this second wave, which was writing on the wall. All countries, America, England, France, Germany, Italy, everybody had gone through second phase, and only we were lying in our own kind of, whatever stupor you can say, that everything we have defeated COVID, and that was not the case. Excuse me. At the peak of the first wave during early to mid-September last year, India recorded little less than 1 lakh daily cases. In the second wave, we have witnessed exponential rise in number of cases, which you all know touched 4 lakh cases. And this lasted for nearly a week, and there was utter panic. While in the whole year 2020, India witnessed almost 1.5 lakh deaths due to COVID, in the first 5 months of 2021, we have already surpassed this number. So daily cases appear to have started receding now, which is a good thing. But the infection rate and intensity of the second wave were not entirely unexpected, given that we let our guard down when daily infections in starting of 2021 fell down to about 20,000. India went into a mode of complete unlocking to revive the economy. Masses gathered for whatever rallies, political rallies, farmers' rallies, and religious events, and people became complacent about the basic preventive measures. I would not blame the government 100%, but I blame the government at least 80% because whatever they say, the people would have done. Anyway, another reason for the sharp increase in infection and mortalities in the second wave is the different strains of COVID-19 at play, which Dr. Gyani had mentioned about. So I'm not going to go into the microscopy of those strains, but in the past 1 year, the virus has mutated many times, and some of these mutations are of great concern. 2 mutations we are already having in India. There is a double and triple mutant, as you know, in India, plus the UK, Brazilian, South African variants that have demonstrated to have higher transmissibility. This time, the variants proved to be more difficult to detect and affected younger people in large numbers. But the good news is that most of the vaccines are covering these variants. Now, I would like to touch upon, for some time on the genome sequencing. Now, this genome sequencing in India for COVID virus was negligible, with less than 1% of the total positive samples which were sequenced. And this is far below the very low target of 5%, which was set by the government itself. Through genome sequencing, a more effective mutation of the virus could have been identified early and contained within the region with strict measures to limit community transmission. This is not a rocket science. You find something new, you just hold it there. With the infection spreading rapidly, India's already strained healthcare infrastructure crumbled. In addition to metro cities like Bombay and Delhi, this time tier 2 cities also faced shortage of beds. Then we were hit by a tsunami of shortages of essential things like oxygen, drugs, ventilators, and above all, what again Dr. Gyani had mentioned, the healthcare workforce. Slowly but steadily, we have been able to deploy stopgap arrangements to save lives, but the battle is not over yet. So please mark the word stopgap, ad hoc. That is what we are best at. The second wave is progressing in smaller cities and rural areas of India, and estimates now suggest 48% of the COVID caseload is now in rural areas. Testing facilities and healthcare provisions are dismal in rural areas. This is the result of gross underinvestment in health by the government, creating wide urban-rural divides when it comes to access to quality healthcare. And this is the point which Dr. Gyani started off with, that the government has been spending less than 1.5% of GDP on health for decades. Forget about NDA government or any other government, but this has been the hallmark of our governments. And according to World Bank, the figure is actually 0.9%. Every year it falls short of its own target. They have created the target, not Dr. Gyani and me. Every year it falls short of its own target of achieving 2.5% of GDP spending on health by 2025, envisioned in the National Health Policy of 2017. And we need to spend an addition of 1.2 lakh crores on health every year to achieve the target of 2.5% of GDP by 2025. So don't even think of 3%. What I'm saying is this has not been done, and this is according to their own reports. The government should prioritize augmenting and preparing the rural facilities to test, track, isolate, and treat COVID patients. Health as a human right should be accessible to all, and people should not be at a disadvantage if they even live in the rural areas. So one small point I want to make, that a government which has gotten into the habit of spending so little on healthcare, so where does the axe fall? The axe falls on us, which is a private sector, which takes care of 76% of all OPD patients every day in India, and about 60% of inpatients. So it is just like the income tax. How many income tax payers are there in India? Maybe 3%, maybe bahut kar lijiye aap 4%. So the idea is to keep squeezing them. And this is exactly what is happening in the healthcare also. That you cannot do something, you never created that infrastructure yourself. And the best thing to do now is to start telling people in COVID times that you will charge 7,000 rupees per day on an ICU bed. Another deadly threat, a nightmare in this pandemic, is the growing number of mucormycosis or black fungus cases now. With an overall mortality of 50%, mucormycosis is a very rare fungal disease, is being declared as an epidemic by Indian states. And incidents of mucormycosis are recorded majorly in COVID patients who are hospitalized for treatment and are linked to indiscriminate use of steroids and contamination of equipment, water, used for administering oxygen. And mucormycosis is increasingly emerging as a problem specific to India, while COVID cases are there in all countries. One possible explanation for this is the high prevalence of diabetes in India. There are around 7 crore diabetics in India, and India is known to be the diabetic capital of the world, where this diabetic volcano is about to explode. So you have diabetes, you have COVID, and you have steroids, and this is a very, very deadly combination. I've always insisted on paying more attention to the rising burden of non-communicable diseases, which Dr. Gyani had said post-COVID. that are responsible for 65% of deaths in India. NCDs are largely preventable and can be controlled with lifestyle changes, modifications, and medical interventions if diagnosed early. So what do? You should diagnose them early. However, India is not doing enough to prevent, diagnose, or treat NCDs. I'll say a few words about the vaccination drive. So mass vaccination against COVID is emerging as a potential savior to end this pandemic. But at 80% efficacy of the vaccine and 70% herd immunity required to control the spread of COVID-19, this tantamounts to 87.5% of our population, that is 120 crore individuals need to be vaccinated. So the target in front of you is 120 crores. With vaccination open for 18 plus population, the requirement at 188 crore doses, but we have been able to vaccinate only 20 crore people till date from 26th of January, of which only 4.5 crores have got both doses, mostly because of shortage of vaccines. In a country which would have been swimming, कहते जैसे दूध की नदियां बहनी चाहिए, वैक्सीन की नदियां यहाँ बहनी चाहिए थी. In early April, we reached a record of 42 lakh vaccine doses administered in one day. On 20th May, we surpassed everything so far, and we gave 48 lakh doses in one day. But these days, we have fallen to about 20-25 lakhs. And this also indicates that we also have the capability on the good part that we can do 50 lakh doses per day, given adequate number of vaccines are available. So we have to increase and sustain the pace to at least 50 lakh doses per day immediately, which was also a commitment given by the government in early April. These are not my utterances. Estimates based on supply positions and purchase orders of the center and states suggest that in the next 3 months, that is by August, we will be able to vaccinate 70% of 45 plus and only 25% of the 18 plus population. We need to sort out the supply side issues. This is not the forum to do it. Place advance orders with manufacturers, expedite approval of other vaccines proven effective elsewhere in the world. Let me also share one small statistic with you that as early as August last year, Americans pumped in 45,000 crores to aid the research of vaccines. And they ordered 40 crore doses in August. EU, European Union, on the other hand, they ordered something like, 40 crore, 80 crore doses, 80. And whereas in India, we were late starters and we ordered only 1.6 crore doses as late as January. So now the figures are in front of you. So currently, central government is procuring 50% of all vaccines and distributing to states for free, whereas the remaining 50% quota is left to the states, private healthcare providers, and corporates to procure vaccines directly from the producers. This will lead to states and private sector unnecessarily competing with each other and negotiating prices which have already been negotiated before. Renegotiate, postmortem ka postmortem ho raha hai. Unnecessarily competing with each other and negotiating prices with producers to gain requisite supplies. We need to adopt, and this is within inverted commas, centralized procurement, but decentralized distribution strategy. This is a must. And this will streamline procurement at the central government level and allowing states to distribute vaccines for priority age groups and high incidence areas. This strategy is not new and has already been implemented by states like Tamil Nadu and Rajasthan. Now, when the government itself has recognized that the third wave of COVID infection is inevitable, we must do 3 things to minimize the impact of the third wave as much as possible. We cannot let our guard down. There has to be efforts put into managing the second wave, including oxygen supply, drugs, hospital beds, opting additional healthcare workforce, vaccine production should only be further accentuated, and we cannot afford to relax or repeat our mistakes and let COVID take advantage of the same. Vaccination game needs to be up, which I have already told you, especially beyond tier 1 and tier 2 towns. And we need to devise village level vaccination camps and door-to-door vaccination campaigns to move vaccination closer to where people can access it. And why am I saying this? Your own Dr. Harshvardhan was a pioneer. He led this attack on polio vaccine, on polio, anti-polio. He has done crores every day, and he's still the health minister. What is the problem? Get people, the private enterprise here, the CSR people, the corporates, the Rotary clubs, the Lion clubs, the NCC, and you will see the needle moving on the dashboard. You can do even 1 crore a day. And the third is reinforced messaging on prevention, proper use of mass social distancing and hand washing. This has to go hand in hand, what is known as COVID compliant behavior. This cannot be, you cannot, fill water into a bucket in which there is already a hole which is leaking. So as we navigate through this pandemic, ladies and gentlemen, it is imperative that we recognize this as an opportunity to bring systemic reforms in our healthcare system and use health to catalyze growth and development of the nation. And we should be able to spend much more money. I will talk only about one more part about money. We can go on and on. Dr. Gyani is already smiling at me. But there have been 7 pay commissions to up the salaries of government people. And not even one, once they have looked at the CGHS rates, they did, but it was a perfunctory kind of a look. So you have got to do some kind of reforms. And I think the time has come now. Thank you very much.
Great words of wisdom and his experience you have seen, because, I tell you, healthcare, we have got so many hospitals, so many consultants, so many, administrators. But I really find in such a big country, very dearth of the people, who keep eye on what is happening, what needs to be done. And Dr. Arvind is one of them, so we always value such people. Now, in my, criminology, now I can go to Dr. D.K. Gupta, because he's running the hospitals, and let us hear from him. During pandemic, how do you really provide patient-centric care? Because some people will, talk to you, oh, how can you ask patient-centric in the pandemic? If we are able to provide some care, that is good enough. Now we are talking of the patient-centric care on top of it. So I think let Dr. Gupta tell us how he has been able to do it and how it can be done. What are the constraints? Dr. Gupta, please.
Thank you so much, Dr. Gidhar Gyani, Dr. Anil Garg, Dr. Ragini Garg, and Dr. Arvind Lal sir. आपने सर बहुत अच्छा बोला है. Really आपने आईना दिखाया सरकार को, हम सबको. सच्चाई यही है, लेकिन लोग मानने को तैयार नहीं है. तो आई थिंक हमें बार बार आईना दिखाना चाहिए, तो शायद उसका कुछ इफेक्ट आए. थैंक यू सो मच, इतना अच्छा डाटा और सही चीजें बताई जो हम सबको समझनी चाहिए और सरकार को समझनी चाहिए. So pandemic, it was really difficult for everybody, not for hospitals, for everybody. It was difficult for families, and everybody was expecting specialized care, but it was not possible at all for anybody to had a benchmark of that quality of care. But still, hospitals were struggling and they were providing the care. There were different challenges from, there were 3 verticals of a hospital we have, right? Clinical part, paraclinical part, and non-clinical part. If we talk about non-clinical part, there was the housekeeping staff, infection control, parking areas, safe distance making in the hospital, green corridor, yellow corridor, red corridor, isolation wards. So the management was very difficult because everybody was afraid from the COVID, and the people were not able to work, but not able to choose the work in basically COVID hospital or even non-COVID hospital also. So the attrition rate was very high. And even in these like lower class of employee, it is very difficult to train them also and retain them also. So that was one challenge in the non-clinical part. And if we talk about paraclinical part, there is an overburden on the labs, radiology, because their HRCT was going huge number and the lab tests were in huge number. There are so many like new profiles of COVID patient profile was coming, and the pressure was for home collection also. I think Dr. Lal is here, he will definitely agree. There was a huge pressure for clinical, paraclinical parts also on labs also, basically from collection to delivery, from sample collection to sample processing, report delivery, report dispatch, were too huge. And the government was daily updating their rates. They were daily dictating their rates. Even now in UP government, we have again one rate that you have to do a CT scan at 200 to 2000 rupees only. And that I think RT-PCR was capped. Every test was capped. And we have made, in CMO has made a grievance committee in this district of most of the UP districts, that people can directly complain and they can take refund from the hospitals also. Even nobody is listening about the hospital, that the consumers who are the vendors who are providing consumers oxygen, medicine, they have increased their rates 2 times, 3 times, but nobody was having like control on them. But everybody was want to control the hospitals or hospital owners or hospital managers basically. So that was a huge challenge. Even in pharmacy, there was challenge, shortage of medicine, shortage of drugs, and like we have seen the flu, sanitizer, mask. Even currently we are suffering that we don't have amputation. We have to, if we have a patient, then we have to ask CMO or district magistrate or commissioner of police to get 4 or 5 injections for one patient, and that require huge follow for that delivery of these drugs. So I think there is a lot of misuse of this epidemic act also by the hospitals and by the government officials basically. If initially in the first wave, if you were having any COVID patient, then you were blamed for that. That was your responsibility, that you should not have any positive patient in your hospital if you are a non-COVID hospital. If you are having, then even the society people or nearby administrative people, they were blaming you. There were allegations. Even I have got 2 FIRs done for my hospital during first wave, because my hospital driver was not able to drop the patient at the same location. He dropped the location, but there was some miscommunication. Even small issues were like escalated too high, that was not required from the government also. Because of that panic, I think people have stigma. They were not like telling that they were not going for testing, tracing. Even the society people were doing stigma with these people. I think there were so many things we have learned from this pandemic. If we talk about the clinical part, there were nursing, shortage of nursing. They were asking high salary, double salary, not working. Even the like we are non-COVID hospital, and the COVID hospitals were paying 2 or 3 times of salary. Therefore, they were not working. They were wanting to earn more. There were high attrition rate of nurses, ICU doctors, physicians, chest physicians, they were overloaded. So there are so many problems that it was very difficult to provide a good patient experience. Patient experience started when patient calls in the hospital. From first step is from whenever he calls the hospital, what is your telecaller, what is your front office staff, how he responds. Second is how he walk into your hospital. What about your parking area? What about the guard area? What about hand sanitization area? What about the green area? What about your infection control guidelines? What about their implementation? There are so many things. I think there were expectations were very high, but we were not able to cope up with them. Still, we tried to it, and occupancy, but normally, we all know that average occupancy across the year in a hospital is around 60-70% maximum. But this time, most of the hospitals, they were running at 130-140% of the occupancy. That means there are operation difficulties were there. And I think if we talk about the vaccination process, like we have started 24/7 vaccination drive also. I think I'm just talking to you, but still there is a lot of rush inside the hospital and outside the hospital also. So in initial days, in January and February, when the vaccine was launched, that there were guidance from the the authorities, even the bureaucrats, even the intellectuals, even the leaders, opposition leaders, that vaccine is not safe. There were so many confusion across the society. Nobody was going to take the vaccine. That the only one who first got the vaccine, they were frontline workers. So they were the guinea pig for that also. But now there is hue and cry. Everybody is forcing us, calling us for like just to get the vaccine or right now out of order, out of queue. So I think there are lots of challenge for us. Even there are calls that we want to vaccinate my home. So it is something that is not possible right now. That should not be expected from the healthcare workers or healthcare providers also. I suggested government during initial days of this second wave that there should be L1 isolation centers in the communities, because there were a lot of pressure on the hospital that can be minimized by setting up small isolation centers. But they took a lot of time. That was implemented, but it was too late. The effect was not good. So I think there should be involvement of private-public partnership. And if we not, because we are providing 70% of the healthcare infrastructure. We are having, Dr. Arvind told that around 70% of OPD we are serving, around 70% beds we are providing. The manpower, nursing, doctors, they are all confined to private healthcare providers, and you are not taking any consideration from them. You're not involving them in SOP making, your guidelines making. That there are like one-way traffic. You are getting the dictating orders from them that this is has to be implemented from now, and you have to follow that. So that, I think, that should not be good for future also, because we cannot survive on this. Like, the rates are quite low. CGHS rate has you not revised for last 7-8 years. There is too low that nobody can survive on these rates. But they are not. They have not got revision from last 7-8 years. Even Ayushman rates are quite lesser than them also. So where we are going? We are spending around 1.3-1.4% of the GDP. Now we are spending more than 2%. The developed countries, those were spending around 10 to 15% of the GDP. They were not able to cope up with this COVID. And how we expect from us that we are investing around 1.5%, and still we want patient experience world class. If we want patient friendly hospital, we want, like, if we want to make a patient friendly hospital, then you have to invest on healthcare infrastructure, on the human power, human resources, doctors, nurses, even the SOPs, even the non-operational part, operational, like, so there is a huge thing. I think government needs to revise their policies, their their thoughts on the private part, how they can involve us. If without our involvement, it is not possible to provide healthcare facilities across the India, because we know it is very difficult for next 50 years. At least they have to be in partnership with the private players, and they should be like active partners. They should not be that. There should not be one-go traffic that they are dictating their rules and we are following them only. And one thing more, Dr. Gani told that like 70% of population is residing in the rural area, and 70% to even 80% of healthcare infrastructure is confined to tier 1 cities only. So there is a mismatch between the provider and the receiver. So I think this is the time that we should convert district hospitals or tehsil hospitals or community healthcare centers, primary healthcare centers. We should upgrade them, so that if we have any third wave or any future pandemic, then we should be able to cope up with them. We don't know that how many people died in this pandemic in the villages area. There is no count. The data Dr. Lal told, that is just given by the government. That can be tip of iceberg only. These are all my points. I think this is a high time we should raise our voice, and we should talk to government that this is the way, and there should be in uniform policy, and policy should valid across all states. The UP is doing something else, MP is doing something else. There are so many policies across the states also. There should be uniformity of the policies also. That is my point. I think I will finish my word with this.
Thank you. Thank you very much, Dr. Gupta. I mean, this is the ground reality. All of you are speaking, nobody is speaking from some written document or paper. All of them are speaking based on their on-ground experience. And actually, government has become aware of it now, maybe a little late. But only point is now, after this COVID goes, little bit subsides in July, I think how we remain vigilant to make sure that even if the wave 3 comes, we are in better positions to combat it. That is basically all efforts are going on. So let me now turn on to Dr. Ravi Gaur, who is another veteran in our field of healthcare. And like Dr. Arvind Lal, he has got vast experience in the diagnostic and more actually in the radiology part. So let us hear from him that what has been his experience on dealing with this kind of patient load, and were he or the diagnostic center as a whole was able to provide the patient-centric care to the patient. Dr. Ravi Gaur, please.
Good evening, sir. This is, I think, good evening, everybody. And firstly, I'd like to thank Dr. Garg to create a forum where we can talk very openly, and we are willing to, speak out in the public front, and then, of course, taking out the learnings from there and making sure that the learnings are now, well, like put across in our practice as we move ahead. the important topic today was like, and we have, of course, I have the honor to share with this platform with our honorable, respected Brigadier Lal, and we have, of course, Dr. Gupta and the team. I think it's always pleasure to hear Dr. Gyani, Dr. Lal. I think there have been I won't say the encyclopedia of wisdom, and that's actually comes from the experience, and I think. Then both of you probably have been leading it from the front, and it's my pleasure to be here. Today, the topic we're talking about how to ensure patient-friendly quality healthcare in the COVID-19, and of course from the second and third wave, basically. Whatever we have learned from the first wave, I think whatever we went through the first wave, we did learn to some extent, but I think we never. We gave up in between. We thought like, oh, this is over, and probably we were complacent somewhere, and that's where we had the crisis in second wave. Second wave was expected, but had we had learned properly, the crisis would have been handled in a better way, definitely. So it's very important for us to that the mistake of getting complacent and not really getting ready for the third wave. That we should not do. I think that's something we should continue this effort, which is started late in the second part of the wave. Because the surge was almost like midway and post the surge, but the havoc was being created. That's the time I think a lot of actions came into place. But I think that has to continue if we really want to, make sure that there's a patient-friendly, patient-oriented, patient-centered, and all of us probably doctors and the providers' safety very equally important here. I will not like to talk on the cost because a lot has been spoken about and it's all everybody has spoken. But I think one thing is very, very important. What we are focusing is on, everybody wants to talk about the product cost, bring down the product cost, and have a best quality product without realizing that nobody is bothered about the recipe of the product. Now, if you don't check, there's no check. Government is talking about bring down the pricing. I don't want the testing part, diagnostic part, CT scan part. There are certain state government, they have come out with some blood test capping price. They're just capping the pricing without realizing what is going on and how to, right from procurement to testing to delivery. That's a recipe of a test, or at least the product. They're not even looking into it. If you don't have any check on the recipe and you just want to check the product or the assay or ultimately, it is a definite recipe for disaster. Ultimately, that is what exactly is happening. All the providers have worked hard, and probably many of them have, from the CSR fund, from all the support, whatever way they have come out, and especially the private sector, they have delivered to the maximum. But now with hard time, I think it's very important to look back into the cost. Because without that, I think come what may, it will be difficult to continue the quality care which is expected, and which is a need even too. The quality is never an accident. It's always as a result of intelligent effort. And that's something what we need to be working on. Now, what more can we do probably to have the quality cost? One is, of course, what we have done is the adoption of technology. And India is definitely a place, but I think private sector and even the government probably to some extent has showed that from one lab in last year when the COVID started, today we have almost like close to almost 3,000 labs which are doing COVID RT-PCR, which is supposed to be one of the most difficult technology. But it was adopted very well, and all the labs are of global standard, ICMR certified, they are accredited by NABL, and they are dishing out both. I think that's something that shows that we have the capability, given the right direction, right support, and of course, if there's a motivation to work on. Because otherwise, it will be people will have come forward. How do they have no motivation? Only thing is like one state comparing with the other state. My rate of COVID PCR is 900, or other states should take 800. If I, without realizing, well, there's a difference of cost between here and there in multiple states. So I think that's competition between the states. I think that really demotivates the private sector. I think we have to, wherever you're having a pricing part, let's communicate, let's talk and make an open forum. Let it be transparent. I don't think private sector is here at this time to make profiteering what they always talk about. We're there to deliver, and I think they have delivered to the most extent. Of course, there are always some black sheep and all these things, but I think that majority of us probably worked very hard and ensured that whatever the cost was immaterial to us. We wanted to deliver, and we had delivered hard. And of course, there was some support from government, of course, at many fronts, but I think much more is needed. Now, the second important, we're talking about, Dr. Lal mentioned about the technology sequencing. I think we missed out that part. Probably there's so much of, you knew the mutations are coming. Now we still know the mutations are going to come much more. These viruses are known to mutate. I think sequencing should be upgraded. Sequencing technology should be upgraded. And probably the volumes, we always talk about the cost by sequencing cost. But I think if you increase the volumes of sequencing, there are facilities and infrastructures in the private sector and even government sector, that n number of sequencers, probably you'll surprise. The more number of sequencers are lying in R&D, they're not actually doing anything. They should be utilized in broad front. We should understand the signature and imprint of the viruses. I think more you understand the nature, more you know the inner signatures of the nature, you will be better prepared for the treatment protocols. This is, I think, one important thing we should prepare going from second to third and invest into it. Now, that will also help us to identify hotspot, maybe which geographies these mutants are working. If we know well the trend, how the virus is going to mutate, and it's like we probably able to control and contain the disease much better. Secondly, the automation part, I think very fast things have to be adopted for automation. We need to really put it automated. I think the private sector automated fairly lot of things, right from the patient booking to patient everything. It's almost like touchless, touch screen kind of a thing, or even more paperless technology they have adopted. I think the automation probably in same thing in the testing part. There are still in the RT-PCR testing which is going on, which is like, people are, they started using, of course, bigger labs, the automated extractors and everything. I think probably those prices can be brought down. We will be able to bring down the costing of the equipment and cost of capex investment which goes into these extractors, and that will probably help to scale up and be ready for the third or fourth wave of any nature. Then in one point, I think we have our friends talking about the skill part. I think skilling is always been shortage. Whenever we have these kind of shortages, I think very important lesson learned onward is the multi-skilling. Because when we have COVID hospitals, all the other NCDs which suffered very badly during the COVID phase, because those 80%, 90% beds were only COVID. Now, how do we skill our guys? Now, that is something which can be skill nursing care areas, RMOs are there, the ward attendants and ambulance drivers are fine, the skilling is happening. But can we provide some? Because today we talk about first aid. First aid is given at the school, teachings are given at the school level and rest of society. But there are certain smaller things like how to use an oxygen cylinder, how to make an oxygen, apply oxygen, the concentrator, how to measure blood pressure, how to make, and they're automated instrument. I think that skilling component probably, if it can be, the common man probably now knows about, because a lot of automation is already happening in that space. So you have an oximeter, which is your value and pulse. How to put them together? I think maybe in our schools at the 10th and 12th level, if that basic information is, become part of their curriculum, they might just without making more of a problem. But I think that will help generation to be prepared for the future, because CPR is like, whenever an accident, that some schools are teaching how to do in the cases of accidents, CPR. That's, I think, similar thing, probably some basic skilling, so that whenever, it's like some countries we have 2 hours army tenure is mandatory. But why? Because if the war happens, these people can come back and take positions anytime in their life. I think something we need to create, be ready for the certain pandemics in future that will help us to deliver. Now, then of course, the one we need to work on is our inventory, the infrastructure. There was actually, though, no listing of facilities. There was so much of utter chaos because everybody was hunting for ambulances. Everybody was looking for the oxygen shops. Everybody was looking for chemist shops providing steroids. And because there of course, later on they started, but there were n number of websites, n number of groups, and n number. We never had one, like verified kind of a thing, which is everything is listed out here. I think there are hospitals of their own private groups started that. Government also started, state governments also that. But I've seen people, even, my personal experience, that people, because I am come from diagnostic industry, but still they feel being a doctor, you must be doing anything here. So they started talking about somebody even calling up at the late in the night. So we need some help in crematorium because we really don't know which, because the waiting in crematorium is for 8 hours, 12 hours, 15 hours. Can you help us out to find out where it is? I think these are the basic things. If we know this thing, this is going to happen. If we have the facility, we have the listing out, we have all this thing, right from ambulance to all this thing, probably that will reduce the panic, because ultimately it is a panic which created, and patient panicked. There's a lot of panic and apprehension which led to chaos, and of course, unhealthy environment, which we all of us, the 10-15 days, that was the very toughest time, especially we had all of us faced. Now, then I think one more thing probably I'll say is, although there are a lot many things we can talk about, one of the important thing is, in hospitals, in our setting, healthcare setting, or even institution, we should have established safety and health management systems now. It's time to do that, because we don't know what is going to hit us next, because it could be COVID today, it could be something else. But COVID itself is so uncertain. It's very important to put up our health and safety and health management system very well in plan and relook into it, because we prepared something which was prepared somewhere in month of last year when the COVID came last year, and after that probably we thought it will continue, but I think we defaulted. When the second surge came, we should keep our system, and this is the time to prepare before the third wave comes in. Build a rapid response team. I think this is another important, because what happened in the second wave, to my understanding, although the hospital providers will be able to tell us better, because we had at peak of the time last year, 80%, 90% of the hospital beds for COVID beds. After that, when it went down, everything was non-COVID, and non-COVID beds were opened up. And when the second wave came, they were almost like hospitals were almost full because of the non-COVID and other things. Now, suddenly they were told in 2 days, now stop down. You have to put, how do they do that? We have to discharge a COVID patient, non-COVID. Can they do that? No. How do they convert the hospital into, I think, the very great work done by the private providers, and I think and the NGOs and various institutions who really came out very, very fast, and they started providing oxygen beds in 2 days and 3 days. But I think a rapid response system, I think, and how to build up a rapid facility, which happens actually, and again, if you look at, I come from an army background, and Ridalal will be able to say that when we move in the Indian Army from one border to another, in the war we move, there is always an advanced dressing station. 4 hours we can set up a hospital, because the territory has to be vacated. The infantry has to move from one place to another place in the next 4 hours. So within 4 hours, surgical centers, 8 hours, they're set up, and they 2 hours they close and they move further. I think we need to adopt some kind of a rapid response, because we may be ready for COVID today, tomorrow maybe something else. There's a learning, I think, so that in future, not only COVID, I think all learnings are taken care of. Then, of course, the awareness, teaching our staff, the employees, all I think probably they have to be reoriented, retaught about its importance, and that has to go again and again in their mind. Otherwise, they become human tendency to become complacent. Oh, it has happened, now then not going to happen to me. But I think it's important to re-emphasize all these points, and that safety is very, very important, and you should be compliant with safety at all if you want a good health, not only the COVID, but entire health. This is like, I think now focus should now go into preventive and good health. I think people are now aware of the COVID, like consequences of not keeping the health well, not taking care of health, how it is important. The diagnostic is important, preventive care is important, eating good is important, hygiene is equally important. I think this tempo should be built up, and that should be actually brought into real practice. And I think now is people have gone, oh, I know I should look after my health, I should look after my immunity, I should eat well, I should exercise well, I should not smoke. I think these are the areas, I think, if you focus on, probably will be a quality healthcare, and of course we will be more prepared as the future move ahead. Then, of course, there are other things, of course, multiple things which we can talk about. The incorporate safety hospital designs in the hospitals, but that's already happening in many hospitals. But then communication was the biggest challenge in this COVID time, because patient one goes inside the COVID ward, Now the attendance and all, India has the Indian probably, our attendants are all waiting outside. That's generally happens. We want to visitors or n number of people want to visit and know about. There is apprehension. I think when good communication system, although many private hospitals and private centers and government centers started following a very different, the norms. My parents, they themselves were affected in COVID, and I have found it difficult to get to know the information because I really wanted to know what's happening morning, evening. But no, I think it took them time before, because it's not that nobody wanted to inform. It was they were overwhelmed with work. Nursing staff, doctors, RMOs, and they were too much overloaded. I think a well-established communication system, if put into place, that will again help a lot of people. If the patient himself is saying, if I am admitted in a COVID, God, what will happen to me? Now I am totally cut off from my entire family. I think technology worked here to some extent. People doing FaceTime, people doing video calls and the difference. But I think that could be a part of the protocol and probably help the hospital and all to come back with some plan to allay the apprehensions and the various problems which can happen going forward. Lastly, before I say, I think one thing I think somebody mentioned here is we had primary care and we have tertiary care. I think the intermediate care in COVID protocols were almost journey was very well defined. More or less in second phase, we knew first day, second day, third day, fifth day, seventh day. After that, of course, uncertainty always exists. But more or less 80-90% of people, the oxygen will go to fall from 94 to 90. If it is 94 and below, it has to hospital, and 90 into ICU, all this. So I think they need to create some, because to have these kind of a situation, if we can have an intermediate care, means when we have maybe a small container, small buses, everything we have at 8-10 beds kind of a thing, which is like for people who are having 94 to 90 as the concentrator. Otherwise, everybody is trying to employ a concentrator at home and a nurse at home for that purpose. So there's going to be some kind of triage if possible. That again, if I don't get something, my 94 oxygen is falling below 94, I can go to this triage center. And if from 90, I can go. Otherwise, everybody goes from 94 to ICU bed, and then the whole ICU bed is occupied, which is not really required at that point of time. So this is, I think, and this is, I'm not talking about many of the big private hospitals doing an exceptionally good job. They were following the protocol. But I think more of as we go tier, Dr. Garg mentioned about tier 2, tier 3, and tier 4. I think this is some stations in between. You have to come back to PSC. After that, come back to this train, come back to tertiary hospital. This intermediate care centers, probably 80% of people will be from intermediate can go back to their home. I think this is something, what are the important learnings and we should be doing in future. So I will sum up with that. But in any case, ultimately coming back to quality, I think, but it's in cost, everything is very important, but healthcare providers that find the right balance among patient experience, quality and cost in delivering value-based care will be the best position and the winners as move forward. And the ultimate winner will be our patients who will have a better outcome and affordable and a better health. Thank you so much.
Thank you, Dr. Ravi Gaur. I think all we can see is such a honest and good intention, the people who are speaking here. And what one mention came, that so much expertise available in the private sector, but unfortunately, it is not being exploited. I use the word exploitation. Actually, in fact, sometimes government must exploit rather this expertise, not them, but the expertise. And they can do whatever they feel like. But I think the question is engaging them in dialogue is the missing part. And that is my major worry, But hopefully something is going to come. There is already a dialogue starting from the government side. They have appointed 12 experts from the private sector. Hopefully something will emerge out of it. And we will be stronger to deal with not COVID-3. I'm not talking of whether stage 3 will come or not, but at least in the all future pandemic, whatever kind of they are coming, we are going to be in a better position. So with that, now I'll look forward to my last speaker of the session, and he's our overseas friend, Mr. Sergey Sukhoy. Mr. Sergey Sukhoy is from Russia, and let me invite him to speak on this subject. How do we provide the quality healthcare, patient-centric in the pandemic, which is a very difficult, subject by itself. So welcome, Mr. Sergey. Please come on. You are mute. Yeah, please unmute.
Hello.
Yeah, you have to unmute. Oh.
इसने पहले वो जूम कभी से इसकी लैंग्वेज में नहीं लिखा हुआ, इसलिए इसकी प्रॉब्लम आ रही है।
ये शेयर द स्क्रीन पे उसको जाना है, शेयर द स्क्रीन।
वो स्टार्ट जूम नहीं दबा रहे, स्टार्ट जूम किसी तरह उसको दबवा दीजिए।
Puneet, please take care.
But actually, he left now. We will rejoin.
Meanwhile, he has started. He has to start. So I will request Mr. Anil Rajdan to share his views on this subject, that is patient-centric healthcare in this time. Mr. Anil Rajdan, please.
Thank you, Dr. Saab, and I think you're doing a yeoman service by this series of seminars on recent crises. It's very interesting to listen to professionals who've been in the thick of things. You see, India is a very diverse country. Each state has its own administrative culture. And I think that administrative culture also percolates sometimes to the professional culture prevailing in the state. It's unfortunate that there was not much coordination, or at least the desired level of coordination in the course of this pandemic, but I think it's been rightly pointed out by some of our eminent speakers that in our basic planning, as well as in the implementation process, you do not prepare for a pandemic. Well, people of my generation know that when the 1962 war took place, or when the 1965 war took place, we were so unprepared. And probably remember that even when there were no air raid shelters and people were asked to dig trenches and jump into them. So it only shows that there are certain harsh, unknown factors and realities which we as a country and as professionals have to be aware of. Citizens have their own role to play, professionals have their own role to play, and no administration which is dealing with different segments in a mixed economy should have some protocols of adhering to those protocols and a certain consultation process, which is not top-down in its approach, but which necessarily has a bottom-up consultation process, and ultimately directions have to flow top-down. But the consultation process has to be from bottom to up. In fact, it's not only, I would say, the practitioners in this particular episode or the government. There's always a third party, and that is the citizenry. You very rightly pointed out that there are various support structures in a hospital, like nursing staff, and I think the best nursing care, to the best of my ability, moves from the strength of your nursing staff, how well trained they are, whether all the diplomas that we are handing out are really to a competent set of people who know the basics of whatever is your surgical antiseptic procedure that is required, what is patient care, and of course, other attendant issues. Patient normally does always land up in a panic, and I can well understand the harrowing time that the medical profession would have gone through, both in the first phase as well as in the second phase, to deal with the vast crowds of people they had to deal with, of patients. And particularly, I think in the first phase, there was total unpreparedness. But I would say that it has been a game, a teaching exercise, and a teaching exercise for government and for professionals how to prepare for the next battle. As very rightly pointed out, it's not necessarily going to be COVID, it could be any other epidemic or pandemic. Well, I luckily have had a very good experience with medical personnel in my field experiences, though I never was in the medical administration of ministries. But I can say that at the district level, the field level, subdivision level, even at the block level, I've had a very pleasant experience of working right from primary health centers to subdivision level civil hospitals, coordination with them, district hospitals, at the divisional level, and of course, living for a large part of my postings in cities like Chandigarh and Delhi with some of the premier institutes. There is, we are all aware, a gross underinvestment on medical infrastructure and lack of appreciation of what is required to go into it. There are two sides always to a story. We have talked of the excellent support which the private sector has given. But it's not a subject today, probably, but let me hint at that we've seen how we have dealt with medical education also in a cavalier fashion. Medical colleges sprung up without adequate infrastructure. Similarly, nursing institutions also turned up without adequate infrastructure. Now, this kind of a approach or process comes from a lack of understanding of the situation. You need professionals, a very strong, I should say, involvement of professionals in policy making, because it is they who know where the shoe pinches. They know the importance of certain factors in hospital administration. And I think particularly in a mixed economy like ours, which tends to, sorry for using a hackneyed expression, move into a mixed up economy, we don't take care of consulting the right experts in the right manner and in a sufficient number, first of all, before we formulate policies. It has been well pointed out that a lot of care should take place at home or in communities. And in the present pandemic, I think a number of communities have risen to the occasion. Because in any situation, whether it is a pandemic, or it's a flood, or it is a cyclone, or it is a wartime effort, society and the professionals have to work in unison. There has to be appropriate communication. And luckily today, I think because of the IT revolution, there is a lot of information dissemination, which has led to a fair amount of citizen education. In fact, sometimes I wonder that if this tool of IT was not available, maybe things would have been much worse. Panics would have been much worse. There are always elements in society who will try and make hay out of a bad situation, or pandemic, profiteering. There's always an overbearing attitude of some people. Those black sheep will always be there in any society. There are patients who misbehave in hospitals. One has been reading about those horrendous stories where angry patients, particularly at least in the vicinity of Delhi, on the outskirts, have misbehaved with hospitals and professionals. That, I think, needs to stop. We have to respect professionals. And at the same time, I think all professionals have to understand that we all work towards a healthy society. As a society, we ultimately serve. And as a society from which we come from and our family members come from. And the extended society is essentially an extended family. There is need for not only first aid education, there's also need for a lot of what is called civics and basic teaching of citizenry and basic, as you pointed out, healthcare, etc., which should form an essential part of education. There has to be close interaction between the medical facilities, which are down till even the field level, and the education department. I had occasion on 2 occasions to be director of school education. And I know the gaps in school education. We are not preparing young people to be well-equipped citizens of the country. A lot of that misunderstanding, mistrust, non-appreciation of the other's role and his difficulties is, I think, part of an education process which is missing. And listening to today's debate. I'm sorry I couldn't tune in the whole time because unfortunately these days there are some mishaps in your known circle and one has to participate in some meetings, condolence meetings, etc. I did find that there is some element of mistrust, or at least some element of, I should say, dissatisfaction between the medical practitioners, the providers of healthcare, and the government on one side. And probably the third side is the citizen. There are always three sides to the story. Now, if this is a learning process, it's always a few good examples which will teach us what went wrong, how could it be prevented the next time. And I think fora like the present one will do a great service if they can compile some instances like this, and the doctors through their medical association, as well as their contacts in the government at all levels, they can, in a more friendly environment, make them aware of the shortcomings. Now, you're all very senior practitioners and very well-known professionals. And I know how close you are personally to the most influential administrators and to the most influential politicians of the country and the most influential parts of judiciary. Some of them have at some stage passed through your portals, and you have great access to them. So I think kindly use your good offices to make each other aware in a friendly manner on what went wrong and how can we improve ourselves. Because it's only a crisis which brings out shortcomings. Happier times don't. We are blessed to have had excellent professionals handling the situation. And I know particularly for diagnostic labs, it has been an extremely difficult time for handling the very, very vast sea, if not an ocean, of workload. And by and large, I think the results have been coming out very competently and very fast. But I think the new methodologies of communication, the new methodologies of some counseling has to go concurrently, because panic should not set in, and we can always control a situation no matter where, at whatever level we are. You are doctors, some of you are probably surgeons also. You know anything can go wrong anytime, even in an operation theater. But you know how to correct it at that point of time. And you have to seek help from all quarters in an emergency. I think this is not an occasion for name calling. It is not an occasion for fault finding. It is really an occasion for trying to learn and trying to improve the system so that we can provide the best care and the best protocols for this management. Thank you very much for asking me to speak, Dr. Garg. And thank you very much, sirs, for having participated in this debate and discussion. Thank you very much, sir.
Thank you, sir. Thank you very much. And I think now our friend Sarji has come prepared with his presentation. So welcome, Mr. Sarji. Yeah, you are mute again. You are mute. Yeah, okay.
Thank you so much for your kind assistance. May I start up?
Yes, please.
Okay. Dear colleagues, dear partners, and dear friends, thank you so much for this opportunity to share to you, I mean the audience, with the latest achievements to be applied into the healthcare practice, globally into the public health, personalized and precision medicine. Oh. No move. Okay, thank you. Very briefly, over the course of its history, the healthcare philosophy have given special attention to the already diseased individual, focusing on a type of clinically manifested disease, so-called nosology, rather than on one's health or so-called pre-illness conditions, while the latter being left in the shade. Next, please. The resources, you understand it now, the resources of canonical medicine have been missed. That's the fact. And thus the clinical efficacy, chronification and disability rates and the human longevity must be drastically improved soon. The next one, please. Whilst analyzing and pre-selecting basic determinants of health, you may look it over here. 3 types major, 4 types major. Next one, please. To be valuable for the implementation and securing the efficacy of PPM model in the daily clinical practice. Next one, please. A group of the recognized experts in the PPM-related area has presented an evidence-based and well-documented assessment of global trends in medicine and healthcare development and strengthens the executive value of the next step model of healthcare services being entitled as personalized and precision medicine. Next one, please. PPM as a model of healthcare services of the next step generation is the science and art, illustrating application of sets of the different tools of the model at the population, communities, and the individuals. Next one, please. Look at that, please, being illustrated. Next one, please. And exerting reliable control over morbidity, mortality, and disabling rates, as well as significantly optimizing the cost and efficacy of treatment for those who had already fallen ill, so-called patients, or for persons at risk is, next one, please. The strategy would give a genuine opportunity to secure preventive, prophylactic, therapeutic, and rehabilitative measures whose personalization could have a significantly positive influence on demographics. Next one, please. Sorry. To implement PPM resources, the unique resources, into clinical practice, there is a strong need to develop a principally new strategy based on biomarkers philosophy. Next one, please. NIH, whilst being a strategic center for medical research and practice, next one, please. It's NIH. Next one, please. Has included PPM model into a list of the 5 greatest priorities of development of medicine and healthcare services in the century. Next one, please. And have prompted setting up centers of personalized and precision medicine being scattered over US. It's just the examples. Next one, please. Next one. Next one. PPM is a goal of healthcare in which diagnostic and treatment decisions are informed by each person's unique clinical, next one, please, basic so-called omics, next one, please. It's just illustrating, next one, please. And environmental, so-called exposomes related information. Next one, please. The crucial element is genomics, is being considered to be a set of the major and unique biomarkers and thus the molecular tools to probe genome for its quality and now even be tested for predictive and prognostic biomarkers. Next one, please. It's just the illustration of the latter told. Next one, please. Diagnostic testing is used to identify or rule out a specific genetic or chromosomal condition. The results of a diagnostic test, so-called canonical test, can influence a person's choices about healthcare and the management of the disorder. Next one, please. Predictive and pre-symptomatic testing can be helpful to people who have a family member with a genetic disorder, but who have no features of the disorder themselves at the time of testing. Predictive testing can identify mutations that increase a person's risk of developing disorders with a genetic basis, such as certain types of cancer. Next one, please. It's just the illustration of predictive DNA testing, so-called scope for today. Next one. Carrier testing for identifying people who carry one copy of a gene mutation that when present in two copies causes a genetic disorder. This type of testing is offered to individuals who have a hidden, latent viral gene pre-integrated into the human genome, or to people in certain ethnic groups with an increased risk of specific genetic conditions. Next one, please. Newborn testing to identify genetic disorders that can be treated early or even pre-early in life, and other disorders, including monogenic and others. Prenatal testing to detect changes in the fetus genes or chromosomes before birth to secure the national biosafety. Next one, please. Pre-implantation testing is a specialized technique that can reduce the risk of having a child with a particular genetic or chromosomal disorders. Is being used to detect genetic changes in embryos that were created using ART, such as in vitro fertilization. The next one, please. Pharmacogenetic tests can be used to predict and to target medicines to good responders, or to identify whether an individual has an increased risk of a specific adverse drug reaction from a particular medicine. Next one, please. It's just the illustration. That's the best choice. The drug not toxic and beneficial. Next one, please. So pharmacogenomics related testing is aimed at tailoring drug therapy at a dosage that's most appropriate for an individual patient, with the potential benefits of increasing the clinical efficacy and individualized safety. Next one, please. The landscape of genetic testing has changed considerably with the emergence of DTC genetic testing. The next one, please. Please. Next one. It's the device. The next one. To secure genetic risk prediction tools for a wider array of common diseases and thus the national health stability. Next one, please. In addition, improved patient outcomes with the use of the biomarker tests must consider not only increased survival or quality of life, but also improved clinical decision support and making, leading to the avoidance of unnecessary therapy of toxicity captured within the rapid learning system. Next one, please. Look at the automatic analysis according to defined algorithm to outline for setting up the clinical decision support finally for the practitioner or physician. Next one, please. Having access to genomic information will become increasingly important as physicians are progressively receptive to incorporating genomics into clinical practice. Next one. But a combination of genomic and phenomic biomarkers are becoming of great significance to be applied in PPM and need to be translated into the daily practice. Next one, please. To predict risks of the chronification and thus of disabling. Next one, please. Genetic risk is the contribution of our genes to play in the chance we have of developing certain illnesses or diseases. As a tool, we can identify genes that increase disease risk. For example, every person is at risk for cancer, but each person's risk is highly individualized. The next one, please. Look, low risk, high risk, early chronic, late chronic. It depends on a combination of genomic, phenomic, and exposomic influences. Next one, please. Phenome is a bridge from genome, proteome, metabolome, which are two important elements of phenome. The next one. Each phenome is being individualized. We may use a phenomenon of phenotype in assessing the individualized phenome, which is coming from genome. Next one. So a combination of genomic, proteomic, and other biomarkers are becoming of great significance to be applied in PPM and need to be translated into the daily practice. Next one. To predict risks of the chronification and thus of disabling. Next one. Meanwhile, every cell has a network of protein interactions, interactome, where those connections within and between proteins and complexes yield insights into cellular states. Next one. Look, it's it's an example of the interactome and the unique complexity of the latter. Next one, please. Metabolome, metabolomics illustrate the functional state of the cell at the level of metabolism, turnover, on a real-time basis, requiring the use of the term metabolome, demonstrating a set of metabolic pathways to be packed within the frame of metabolome. The next one. And finally, who will patients or persons at risk and their practitioners and physicians trust to store and interpret the clinical data collected, harvested, and mined? Next one. Healthcare information technology, healthcare IT, does offer a potential solution for those barriers. Next one. Look at the scope of medical information systems, which are available today in PPM-related practice. The next one, please. Cloudy technologies to connect hospital-based network in all over the world. Next one, please. As a result, a patient or a person at risk, next one, becomes a data carrier. Next one. Look, average 665 terabytes. Next one. It's becoming clear that further development of molecular technologies, risk prediction algorithms, and clinical decision support is much needed. Next one. Very briefly about modern therapeutic modes and approaches. Next one. Cellular therapies, well known. Next one. Genomic editing. Next one. It's an illustration of the latter. 3 alternatives for genomic editing: correction, insertion, or knockout. The next one. It's the only example, I mean clinical example, of genomic editing being used in treating incurable leukemia in US and UK together. It's a fantastic outcome. Targeted cancer treatment. Next one. Very briefly, but much valuable. Individuals to be under regular monitoring that helps to detect pathological shifts at subclinical stages, have a higher life expectancy, and are able-bodied up to 8 to 15 years more than those under traditional canonical treatment. This means that the society would save more than this figure per person annually. At the community level, the annual savings from each individual may vary from several thousand to several tens of thousands US dollars. Next one, please. In this sense, due to our viewpoint, all healthcare professionals of the future should be educated to deliver patient-centric care as members of interdisciplinary teams, emphasizing evidence-based practice, quality improvement approaches, and bioinformatics. Next one, please. Look at that, illustrating the letter said. Centric care. The next one. So the current model physician-patient would have to be gradually displaced by a medical advisor, healthy persons at risk model. The next one. But who is expected to be responsible for getting PPM model armed? translational medicine and its applications to be focused on bench to bedside and back research. Next one, please, the illustration of the latter. Next one. This approach mentioned should be based on postulates which will change the incarnate culture and social mentality. Next one, please. And thus the above mentioned PPM model and tools of translational applications would need for novel training, since the society in the need of large-scale dissemination of novel systemic thinking and minding. The next one. And new educational platforms in the rational proportions. There would be not a primitive physician, I would stress it, created, but a medical or biopharma artist to be able to enrich flow-through medical standards with creative elements to give for a patient a genuine hope to survive, but in turn for a person at risk, a trust for being no disease. Next one, please. So the different sectors will be required to develop new and creative business models and such as products. And no doubt, new generations will speak about the century as a time when medicine became preventive and personalized and its outcomes predictive and guaranteed. The next one, please. On behalf of European Association for Predictive, Preventive and Personalized Medicine, EPMA Brussels, International Society for Personalized Medicine, Tokyo, Brussels, and the Personalized Medicine Coalition, Washington, US, let me invite our colleagues from all corners of the big globe to form targeted international research teams from moving ahead in the PPM and PPM affiliated areas as applicable to managing chronic disorders. The next one. Thank you so much for your unique patience.
Thank you very much. Fantastic, very informative. And we will go by your invitation and we will accept your invitation. We'll join the team of experts to work with you. And do I have Dr. Arvind Lal presently here?
Coming from me, thank you so much personally for your personal support of the moving ahead and hope to move ahead together.
Wonderful. Yeah, we will definitely join hands together and we accept your invitation and we will involve you, the work which we are doing in India, and this networking with you is going to help the whole world. So thank you once again for your generous offer and the excellent presentation. Dr.
Thank
Ravi,
you
thank
so
you
much for your personal help.
Yeah. Dr. Ravi, you have any question for Sarji?
Sorry?
Doctor, I am asking my colleague, Dr. Ravi, if he has any comment on your presentation.
Thank you so much. I would be much happy to. Yeah, bye-bye.
Thank you so much. It was a wonderful presentation, and I really, went through. This is the era of personalized medicine, and this is, I think, where you're talking about integrating the genetics, environment, and the actual, whatever the disease is, putting them together, making them personalized. And I'm sure because. I don't want to understand, because I think similar applies to everywhere. But in terms of COVID, what has happened? In terms of COVID, because it was probably more of nobody talked about genetics part here. We just talked about what is happening in the environment and getting a disease. And how do you apply this learning to COVID and, of course, the infectious disease as we move forward? That's something I'd like to.
If you would not mind, may I share with you very briefly comments? We are not restricted only with bacteria and microbes. I mean, not restricted only with infectious disease. Three global chronic diseases are involved: infectious, cancer, and autoimmunity. You understand me?
Yeah.
Yes, perfectly right. We agree.
Yeah. So anyway, in a couple of weeks, I would send some comments to the president of the Congress, which would be re-sent to you personally. Okay?
Okay. Thank you so much.
Thank you very much.
Thank you for your comments. Thank you so much.
Thank you. So I think
Take care.
Yeah, very nice. So Dr. Anil Garg, with that, actually, we finished our program today. We have overshot by 15 minutes, but it was worth, because the kind of learning and networking which has come through in today's program is really fantastic. If we can sum up all this together, make a small paper and give it to the government of India, it will go a long way. So over to Dr. Anil Garg. Thank you very much.
Keep
safe. You, Dr. Gyani.
Keep safe.
Thank you, Dr. Yeah. Thank you, Dr. Gyani.
Yes.
I will like to invite Dr. V.K. Garg to have a brief comment on this total program. Dr. V.K. Garg, please. Please unmute first. Dr. Garg, please unmute.
Anilji, thank you very much. A lot of discussion has taken place. I'll request Dr. Gyani that giving a paper will not help as suggested by Mr. Rajdan. This paper will go and get filed somewhere in some file.
Okay.
So what is important is, as the conference is patient-centric, and patient and doctor are two inseparable factors. Both survive because of the other. So in order to have this partnership, interdependent relationship, and integral bond, which starts from the time of birth and goes till one leaves this world. Therefore, the more the personal touch, the more the personal approach, as the biggest of the big and important, most important of the important, pass through the doctor's knife or the doctor's table at some day or the other. So the doctors have the resources, capability, competence to tap on those resources and make them realize that, look, to make this relationship more meaningful, to serve you better, there is a need for mutual appreciation. Both the problems, the constraints, the shortcomings, because no system is perfect. At one stage, it was appearing to us that Indian system is far better than the American system. When we went 2 steps, we realized the planning, then we found again the American has overtaken the Indian system. So this is all a game of learning, planning, and relearning and replanning. This pandemic has taught us a lot, and this has given a lot of innovative ideas to our doctors, to our what you call as the clinical paramedicals, and the medical infrastructure support staff, because the first interaction with the hospital starts the moment the vehicle enters the gate of the hospital. The parking, the receipt, the emergency attendance, all this requires manpower, and manpower cannot be generated or trained overnight. It takes years to make a doctor. It takes decades to make a specialist and good surgeon. So this has to be now onwards seen in the light of what has been faced by everyone, that the medical education, its cost, its affordability. One of the most important part in medical education today is its affordability. And last but not the least, the faculty. We have set up aims in every state capital, but where is the faculty? Because the opportunity to grow in terms of career are very limited and confined mostly to the metros. As Dr. Gupta said, we have 80% patients outside the metros and 80% of the facilities are inside the metros. So this mismatch needs to be corrected, in that both the government, the what you call as the, I would call the patient, not the patients, the society, civil society, and the professionals, they all, and the financial institution, last but not the least, because it has to be a PPP, partnership mode. Funds also have to come from somewhere. And once the funds come, there is an investment in infrastructure, in equipment, because equipments are very costly, in chemicals, in reagents, in various investigative instruments. The investment has to come, and maybe that investment, that particular equipment is used only twice or thrice a year, or 5 times a year, but the cost is there for the whole year. So all these things are very sensitive, and there is a need to create awareness of the hospital costs among the society. Today, the people have the idea that oh, he's charging so much, but he's not realizing that maybe this equipment was not used for last 6 months, but the cost was being incurred. The operator was to be maintained. So these are the issues which will bring appreciation to the doctors from the society, from the people who matter. And that is where we need to go, from a patient-centric and doctor-centric and the medical profession-centric infrastructure, qualification, education, investment, planning, and last but not least, the spirit of mutual appreciation and cooperation. Thank you.
Thank you. Thank you very much for summing it up so nicely. And maybe I think one of the program next time, we can design around the community, where we invite the community leaders also to interact with us, and we have very meaningful discussion. And because I keep saying that in America, for example, the medical or healthcare is one of the election agenda. In India, healthcare generally has not been the election agenda, but it is happening now. I think people are becoming conscious of the needs of their healthcare. So I think next time we will design something like that, and Dr. Anil Garg can do something like that, a prominent community leaders and from the civil society, and we bring experienced people who are running the hospital and 2 persons from the government. I think that kind of 5 or 6 of people of us can discuss this subject next time. Thank you very much.
Thank you very much. Thank you. Thank you, Anilji.
Thank you, Dr. Gyani. Thank you very much.
Rajan sahab chale gaye
Before, yeah?
Mr. Rajan chale gaye?
Yes.
Okay.
He's here. So before I have to give a vote of thanks for a minute, I will request final word from Mr. Anil Rajdan, former Secretary Power and Chairman Environment Foundation, to say final comment, please. Anil Rajdan.
Thank you very much, Dr. Garg. I think we all stand enriched by today's discussions. And I think while the practitioners in the system, in the thick of it, gave their views, we had an excellent look into the future medicine and extremely personalized healthcare and prescription from Professor Sergey. And it has to be, medical care has to move to each individual. We in India are quite aware of what we call an astrological chart for every individual. And here, the genome mapping, the genetic mapping of a person, that I think is an extremely important part of medical care. His features, his susceptibilities, as well as his responses to various systems. Now, that is making medicine personal to the person. That I think is probably the future of medicine. And I think all the eminent professionals who have participated today have appreciated that. And their views, I think, which they've expressed are very well taken. We know the Herculean task that they have performed. And I think we all are wiser after this pandemic. On behalf of the foundation, I thank each one of them for having taken off their very valuable time to participate. And Professor Sergey, yesterday we were expecting you, but we missed you. But today you gave us a very good exposition. Thank you very much, sirs, for all your participation. And thank you, Dr. Garg and Dr. V.K. Garg, for being part of the discussions today. Thank you so much. Good night.
Thank you, sir. Thank you very much, sir. Thank you, Dr. Gyani. We will just organize international conference in April 15 and 16. Infrastructure and other things, they are the part of the conference as we have become wise to understand and appreciate it. And at the same time, our foundation is thinking mode of giving recognition to the COVID warriors, those nurses, paramedical staff, doctors who had laid their life for this cause, and also they are surviving and they have done a Herculean task. So kindly recommend their proposition and nomination for that. So we seek your support in that also. Okay. Thank you very much for giving time. And Dr. Madhavan, you have done food for thought and food for healthy living yesterday. Thank you very much. Thank you, Dr. Gyani. Thank you all. Thank you, Dr. Ravi. Thank you, sir.
Thank you. Good night. Well done.
Thank you, sir. Thank you, everybody.
Safe living to everybody, sir. And thank you very much, doctors. We all heard about you and we keep hearing good things. Please keep up the good work.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Good night.
Thank you, sir.
Puneet.
हाँ जी सर.
Uttam.
Yes, sir. Namaste, sir.
Everything is okay?
Yes, sir.
Okay. डॉक्टर माधवन?
माधवन जी, डॉक्टर माधवन जी चले।
ओके ओके, पुनीत ठीक हो गया?
हाँ जी, अच्छा हो गया सर। और बाकी स्पीकर भी सब
तो
अच्छे आ रहे सर।
स्लाइड तुम मूव कर रहे थे?
हाँ जी,
आवाज नहीं आ रही?
आ रही है सर।
स्लाइड तुम मूव कर रहे थे?
हाँ जी सर। वो एक्चुअली
अच्छा।
उनसे कुछ वहाँ पे प्रॉब्लम थी।
हाँ, नहीं ठीक हो गया, ठीक है,
ठीक हो गया।
चलो ठीक है।
अच्छा।
हाँ, आज का बढ़िया हो गया। थैंक यू वेरी मच। ओके, बाय।
बाय मैम।